Welcome everybody to the Child, Family, and Community Wellbeing Learning Series. Next slide, Kush. Today's topic, funding primary and secondary prevention strategies, part 1. This is a big topic, so we're really going to try to break it down for you today with concepts and frameworks for you to think about, and then we'll set the stage for part 2 that will be in September. This year's learning series has been focused on making the ideas in county prevention plans a reality in local communities. To date, we have explored critical concepts and frameworks to support successful and meaningful implementation. We've explored race equity and inclusion, targeted reduction of disproportionality, principles of co-design with community, asset mapping across social determinants of health, the importance of building community pathway that provides collaboration across family serving systems to develop an integrated and holistic network of family and community support. Today, we will begin to explore the funding opportunities available through CalAIM and how to leverage the system of care for planning and program development. Today's forum, like the ones before, have been developed in service to the creation of child, family, and community well-being system committed to race equity, social justice, and tribal sovereignty. Each of the learning forums start with an acknowledgement of our collective history as a step towards reconciliation and a constant reminder of our intentions, purpose, and goals for why we are coming together. In order to address centuries of collective harm and trauma to African American and tribal children and families, we must make an intentional choice to rebuild communities in an equitable manner. I acknowledge that I am sitting on the traditional territory of the Kahula people, who are the rightful owners of the land we now call the Coachella Valley. I also want to acknowledge and pay my respect to our African ancestors for the enslaved forced labor they had to endure for this country's development and economic progress. We want to encourage everybody to do their homework in this area, and I think a couple of links will be going up in the chat. Our goals for today is really to have a conversation about design and application of funding strategies, establish connections between effective, sustainable CPP funding and the system of care as a structure to hold those opportunities. We want to deepen the awareness of critical behavioral health funding opportunities and reforms that will lead to CPP and related successes. And finally, we'll set the stage for the follow-up panel presentation on these critical concepts and strategies. To help us do that, we have a really impressive panel. First, Alex Briscoe is a principal at the California Children's Trust, a statewide initiative that seeks to improve child well-being through policy and systems reform. In 2009, he was appointed the director of the Alameda County Healthcare Services Agency, where he led one of the state's largest public health systems, overseeing health and hospital systems, public health, behavioral health, and environmental health departments. Mr. Briscoe's work has helped design the nexus of public health and public education. He has designed and administered a number of mental health and physical health programs and services in child serving systems, including home visiting programs, programs for medically fragile children, and clinical and development programs in child welfare, juvenile justice, and early childhood settings. We're lucky to have Alex. Thank you for joining us. Richard Connect is a friend of the series, and he has delivered program operations, leadership, strategic planning, and training services to public and private healthcare and human services systems for more than 32 years. He presently provides consultation and technical assistance to CDSS and their partners, as they implement interagency and cross-sector practice initiatives, including Continuum of Care Reform, the state's Integrated Core Practice Model Guide, and AB 2083 System of Care. Prior to consulting, Richard led Placer County's Children's System of Care for a decade. One thing that is new to me that I didn't know about Richard that I'm highly impressed by is that he is the author of 2 children's books. His latest, Scary But Not Very, helps parents explore trauma with young children. Richard, I'm going to look it up and read it. Thank you for all of your contributions to the forum, and welcome back. And finally, Kush Cooper. Dr. Cooper is an adjunct professor at UCLA Luskin School of Public Affairs, as well as the CEO of Implematics, a consulting firm serving public and private organizations in the areas of foster care reform, LGBTQ youth and systems, implementation science, and leadership development. She has been our constant moderator of the learning series. So with that, I will turn it over to Kush to get us started.
Thank you, Dana. You're not going to hear very much from me today. I want us to be able to mine the knowledge that Alex and Richard are going to bring to us, every second of it. Just as setting your context, we have been anchored in race equity, or what I call primordial prevention, primary prevention, and secondary prevention this year. And we have talked about what community pathways look like, what it looks like to serve families who are not yet at risk, what it looks like to serve families who are at risk. But it's always been an ongoing question in people's minds. Well, okay, I get we want to do this. I get why we want to do this, but how do we fund it? And we want to bring you this session here today because we want to we've been, from a funding perspective, it appears to me, been in a dark room trying to find the light switch. And so we want to turn on that light switch today, and there's a lot to see. We might have been in the dark. Your eyes may need to adjust. A lot's going to get thrown at you, but at least we will set the stage for what it looks like to have conversations that reach out across agencies, what it looks like to blend funding, because we run the risk, if we don't do that, we run the risk of misusing the child welfare and probation funding we have now by not leveraging it or attaching it to all these funding opportunities that are out there that support the same children and families across systems. So that said, I'm going to turn it over to Richard to set the stage for all the funding that might be out there, and then he's going to turn it over to Alex Briscoe to talk about a really significant example of a funding stream that needs to be talked about in a system of care context to be maximized fully. Richard, please go ahead.
Kush, thank you. Appreciate that, Dana. Appreciate the introduction. And it's really great to be with a lot of familiar faces. Good morning. Happy Wednesday to you all. It's especially a privilege for me to share the conversation dais with Alex Briscoe, who's a thought partner now for a number of years and someone who inspires and challenges me continually. So I appreciate that, that opportunity. I need to disclaim that while I'm here with the support of the Department of Social Services, I don't speak for the department today, so be mindful of that. And again, great to see some familiar faces. You can go ahead and advance for us, Kush. As both Dana and Kush have mentioned, the issues of disproportionality and overrepresentation and underservice are rooted in longstanding systemic inequities and racism. And it's important to acknowledge that the comprehensive prevention planning process, the plans that counties and partners have put together, and FFPSA writ large, are perhaps the best opportunity in a lifetime to address those things. And if we can successfully use this moment in our reform history, if you will, to address these issues, we're going to finally make progress in ways that we have not historically. And this is critical awareness. Although we've made progress as a state in the last 2 decades, one of the things that's really self-evident, you don't have to dig very deep in the data to understand that we have underutilized Medicaid as a tool in this area, and that we have often disconnected mental health services for kids and families from the negative outcome of entry into welfare. And what we want to come away with today is this really critical awareness that significant reforms are happening in the Medicaid industry. You're going to hear Alex talk about many extraordinary opportunities to expand and enhance that. But we have to do that with the awareness that the cost to failure in that regard is entry to deep end traumatizing systems. And we'll make this point over and over again and talk about ways that these things connect. In order for Medicaid to play this role, this transformative role, it has to be reimagined and transformed. And we have to let go of much of the artifacts of how we've done mental health services for kids and families, behavioral health care for kids and families in the past, and recognize that that transformative capacity lies there. Likewise, the child welfare field, and we are doing this, I will say, in many respects, in order to play a full role in prevention, has to let go of its policing framework. And we are largely down a pathway of that already in terms of moving towards community supports instead of mandated reporting. Next slide, Tush. This creates, of course, a complex adaptive dilemma, right? The prevention planning process locally, the federal and state reforms here provide this extraordinary opportunity to transform systems. And they do so by allowing application of federal resources in ways that we have not been able to do before, and by installing evidence-based practices in a specific cohort of young people in our communities who previously would not necessarily qualify or have access to EBPs or the very effective early interventions through a mental health lens. All of this, of course, requires an alignment of system partners to do, because the children enter typically in one arena, but the resources fall within a different arena. And that's why you'll hear us emphasize over and over again today the necessity of being in a system of care-like structure in order to maximize this opportunity and address the dilemma. While FFPSA has many goals, the prevention plan process that many of you have been involved in locally over the last few months, which culminated in your submission sometime in the last week or so, is inherently complex. While it's technically challenging, it's going to require adaptation in ways that we have not maybe previously thought of. You're going to need a structure in which to hold the technical solutions, because they are interdependent upon multiple partners within the system. And we're going to talk about ways that we think the system of care work allows you to make progress in that regard. Next slide. Just exploring some of the complexities of this and the reason that partnership is needed, and that no one agency can do this alone, is that there are still some things that are still yet to be determined, right? We're trying to gain emerging clarity around the payer of last resort guidance that FFPSA and the use of 4E dollars in a different way forces upon states and local jurisdictions. There'll be questions around how we design and implement and roll out evidence-based practices to a new population potentially in your community. The state block grant dollars are likely time limited, right? The clock is ticking, so to speak, on those dollars. And so we have to kind of make hay while we can in terms of how the state has augmented the FFPSA work. The CARES information management system, the re-engineering of CWS CMS is not complete and will not be for some time. And this creates a significant complexity to reimbursement and documentation. And then on the larger scale, there are parallel upstream reforms that are happening. And while they while they stress the resources of prevention reform work vis-a-vis FFPSA or the state's FFPS plan, they also provide points of leverage. Other reform that's intended to move us upstream, as Dana pointed out in her introductory remarks. These things include some of those listed here, and we'll talk about them in a little bit greater detail as we move forward. All of this to say, we have to begin as leaders in local systems to think less technically and more adaptively, but also open ourselves to the technical knowledge that's present in our partners' organizations. And again, this is why the system of care work is so critical. The thinking adaptively happens best in partnership. The creativity and the innovation come best in partnership with those who have different resources and who see the world, the service delivery world, differently than we do. Next slide, please. Here's a look at the larger ecosystem of those prevention opportunities. And we won't spend much time on this other than to kind of use this as a frame that while the FFPS work and the CPP, the comprehensive prevention planning process that you've been involved in, is part of an ecosystem, there are parallel reforms and opportunities going on, all of which on some level can connect via your Medicaid dollars, your Medi-Cal mental health monies. And Alex is going to talk to us about, again, the technicalities of that. The ecosystem of prevention resources is vast. And time permitting, on the end, we'll talk a little bit about some of the early plans that have been submitted and just how interconnected we're beginning to see the world. Think of this as the matrix of prevention, early intervention opportunities, and it's not just about prevention of entry to child welfare. Next slide. If you're unfamiliar with FFPS work at the state level, very quickly, it's an opportunity to basically waive what used to be board and care monies into prevention dollars, right? We mentioned payer of last resort. What this requires, of course, is a resetting that Medi-Cal Medicaid dollars are no longer the caboose on the funding train. The caboose on the funding train is now 4E. And so there are some significant calculations and design work that have to go into figuring out just how to apply that locally, right? While the child welfare and probation agencies and the county behavioral health partners are primary responsibility holders in building strategy underneath the comprehensive prevention planning process, other agencies within your system of care work share the generic resources via things like care coordination. So the reason your regional centers and your courts and tribal partners and others are involved in your system of care work is that while they don't hold primary responsibility for CPP work, they bring resources in many respects that would enhance and deepen it. What's important to recognize is that the interagency leadership teams and the fiscal managers that support them are deeply interdependent. And the necessity of investing in that interdependence really requires a focus on establishing how fiscal managers, budget analysts can come together across the ecosystem to understand each other's worlds, to know where those points of leverage can happen and be fully maximized. There are business processes that are technical, and while we can never master those for our partners, we have to have awareness of them so that we can see the connecting points. And you'll hear Alex talk about this in some detail. Next slide. Prevention of entry to foster care has historically been, has not historically been, nor can it be the primary responsibility of the welfare system. It's only been the last 15 years or so that child welfare has begun to have kind of permission, if you will, through both code and funding to see itself as a preventative entity. CPP, the FFPSA work, maximizes that in some real ways. Historically, though, the resources that families need to stay out of the welfare and probation system, those belong to other entities, right? And we've made significant adaptive capacity in the last 30 years has been developed. But again, most of the tools to keep children safe at home and community, they are in other people's budget and purviews. And this is why the system of care work is so critical. Increasing numbers of children and youth in and around child welfare are going to be getting their mental health and behavioral health care through managed care organizations. Alex will talk about this in detail. And so we need to begin to think about how those managed care partners will interface with your interagency leadership teams and your existing county and regional center partners. And then finally, by way of context setting, one of the things I try to continually remind myself and my thought partners about is that we can never get to whole child care or to wholeness without a structure to integrate us, without being one. And so wholeness and integration of the services we're talking about ultimately increases access, increases coordination, and the sustainability of our programs in ways that we have not, frankly, not done in the past in California. Next slide. A quick visual look at this concept we're talking about. Really, there are cogs in a mechanism. It's a complex mechanism, lots of moving pieces, and increasingly to have the kind of outcomes that CPP and other prevention efforts envision, the moving pieces, the cogs, are driven by processes, drivers, functions that are outside the purview of welfare and probation. And so this just invites the necessity of recognizing that there are significant resources within your partnerships in and around welfare and probation that can support you and your community partners in developing pathways to prevention services that we've not historically thought of. There's no way that welfare and probation can effectively prevent entry to their own systems without their partners. We've been trying to do that for decades. And what the CPP really demands of us, invites of us, and demands on some level is putting into practice now this recognition that prevention into those systems is largely a collective responsibility, and that we need each other's tools and toys, so to speak, to do that. Kush, let me send it back to you for a quick transition to Alex, I think. Or is this me? One more slide for me, sorry. Yeah, let's back up there just for a second. A quick look then at a few of these opportunities in some detail, right? So if you're connected to school partners, you know that there are, over the last 12, 13 years, significant investments across the state in multi-tiered systems of support. These have primary, secondary, and tertiary prevention architectures, just like your CPP plan does. They're building school wellness centers, community schools. This Department of Education has endowed a grant program that's funding the development of community schools that can only be successful when they are done in partnership, because they're not sustainable. They're time-limited dollars, right? Local accountability plans, LCAP, right? You know, your school partners have now, I think, 16, 17-year-old allocations to prevent and support, to prevent entry to services, deeper services, and support academic and educational success and social emotional learning. We won't talk about it in detail, although Alex will spend some time on CYBHI, and it's one of its larger components, which is the Student Behavioral Health Incentive Program, all of which, again, will invite us to new partnerships and deepen the relationships we have with our partners if we're going to be successful in this regard. Kush.
Great. Thank you, Richard, for turning on the light switch. And now we're going to turn it over to Alex Briscoe to show us what's on a couple of the walls here with regard to CalAIM and school-based initiatives. And let me get one thing here. Okay, Alex, go ahead.
Great. Everybody can hear me?
Yes.
Good. I can't help but be reminded. A mentor once said to me, we have the most complicated descriptions for the things we understand the least. And I can't help but see the overlapping reforms that I'm about to talk about and the history that Richard just talked about. We're all struggling together to overcome the impact of 400 years of structural inequality. And anybody here who says they know how to treat away or case manage away racism and poverty hasn't seen the things that I've seen. So one of the reasons it's so complex is we're trying to do something that's really, really hard. So I want to offer that context. And I also want to say that I'm going to talk fast and I'm going to go over a lot, but I'm going to try to leave everybody here with a set of actionable things. Like, don't believe the hype. There's actually just a few set of things that are happening that will bring new money and resources to your world. And I love to see the first 5 participation here because one of the biggest ones is the new dyadic benefit. So we're going to dive into those very specifically, but I'm also going to try to teach you the structure of Medicaid. So go with me. Here we go. For those of you who aren't tracking who I am, which hopefully that's most of you, I am a recovering bureaucrat and a defunct therapist, and I'm leading a 5-year initiative to try to reimagine the social and emotional health of children in the state of California. We are the Children's Trust. We are a 5-year initiative. We're 4 years in almost, and we set for ourselves some simple goals. We said that we wanted to shift agency and power, meaning reimagine who does the work and who gets paid to do it. That's a fancy way of saying workforce reform, and I'll get into some of the new provider types in Medicaid in a second. We said we wanted to spend a whole lot more money. So we were very much involved in the design of the Youth Behavioral Health Initiative and the Community Schools Partnership Program and a number of other reform endeavors that we'll get into. But we also knew that we have to expand who's eligible for care, that frankly, the pathologizing of low-income communities has been complicit in some of our failures. And we, to many of Richard's points, know that we had to increase transparency and accountability, create a more simple system to administer and navigate. So this is who we are at the Trust, and I'll go into the specifics of each one of these a little bit later. But to crosswalk some of this work to the child welfare system, the child welfare system, like Medicaid, is in the midst of a fundamental systems transformation. I know this because I was the health director in one of the 2 counties that were a 4A waiver county. But if we go back and quickly look at the history of child welfare from the Social Security Act through the Child Abuse Prevention and Treatment Act, through the 4E waivers, through FFPSA to today, we are now reimagining the definition of child welfare and trying to get away from some of the surveillance and paternalistic nature of the system and trying to get at some of the root causes of, frankly, poor health outcomes or poor personal outcomes of the people we serve. And when we look at the nexus of Medicaid and child welfare, there's upstream prevention, what we're going to focus on today, but there's, of course, obviously, some more direct prevention activities that happen in evidence-based models, as well as specific services targeted to young people who are currently the 55,000 kids in out-of-home placement. So Medicaid has a role in each of these 3 areas, but today we're going to be more focused on these upstream ones because I think I made this joke to Dana before we started. I showed these slides to a mentor of mine last night, and he said, geez, Alex, that's a lot of slides to make the point that both Medicaid and child welfare serve poor people. And that's one of the arguments I'm going to try to kind of clarify for us all, that between 85 and 90% of children who are removed from their homes were eligible for Medicaid at the time of removal. Couldn't we reasonably agree that if low-income communities got everything they needed from Medicaid, fewer kids would need to be removed? That's kind of the point of what I'm trying to say. And that's really, highlighted in this graphic, which is, I think we are now working in a common purpose, meaning both child welfare and healthcare is realizing you don't treat away or care coordinate or case management away the social determinants of health. Like child welfare is looking at these upstream stuff. Healthcare has realized the same. And that's what really the opportunity is that two major systems are now aligning around a set of desired outcomes. Yes, which we would call the social determinants of health, which distills to things like meaning and purpose and housing and food and other concrete supports. So what are the opportunities for Medicaid and prevention? Well, the feds are encouraging us, and on the right-hand side of this slide are some guidance. We often talk about fragmentation, like between child welfare and juvenile justice and healthcare, but we don't often talk enough about fragmentation between the feds, the state, the county, and the provider class. So the feds are inviting states into a number of new opportunities to talk about this nexus of Medicaid and child welfare. Some of them are listed here. And why haven't we been successful? Well, an outdated notion of medical necessity. And I'm sure folks who work in child welfare have had that problem, right? You refer someone to the healthcare side and they say they're not sick enough. And that's like salt in the wounds of saying, wait a second, well, there's some really big important changes that have happened, which should really minimize that problem. You may not be feeling it yet, but I want to arm you with the detail on it so we can overcome it together. But this culture of the medical model is clearly a barrier we have to overcome. The obvious administrative issues, and as well as numerous state budget limitations. I know not everyone agrees with me on this front, but having administered these systems at the local level, the fundamental truth of them was scarcity. We were not spending enough money. Now, I agree with Richard and many other people who say we need to spend that money far more effectively in a coordinated fashion. But I also know that scarcity is a predominant problem. Like if we had more money, we would do better. So states can do some things. If you sort of distill some of the guidance that the feds are saying, we can mandate screening tools like the ACEs screening, like ASQ, like the Staying Healthy assessment. We can offer fiscal incentives for social care, some of the new waiver programs that are coming out, including the activity stipends that the state has approved. We can do these service directories like you probably have seen them, from One Degree to Aunt Bertha or Find Help to Unite Us. These are emerging as important tools that can link systems together. We can expand the provider class, meaning create new opportunities for people with relevant lived experience to get paid to do what they work. We can remove diagnosis as a prerequisite for care. I'm gonna say that again, because that's a really big one. It just happened. If you don't know it, it's done. You no longer have to have a diagnosis to get access to Medicaid. It's really important for folks to watch it. And we can expand access to non-clinical settings like we just did with schools. Beginning in 2025, schools become essential community providers, meaning any service delivered on a school site must be paid for by a managed care plan. It's a really big thing called the all-payer fee schedule. So here's the essential strategies to reforming this system, and I'll go into some of its challenges in a second. The first is, and I'm like a broken record here, remove diagnosis as a prerequisite for care. You don't have to have measles, mumps, or rubella to get a vaccination. Why do you have to have a diagnosis to get access to mental health? I want to congratulate our partners at the state who have actually taken this action. It hasn't shown up in your world yet, but it's coming. We have to reform Medicaid. That's happening. That's what CalAIM is. We have to center schools and pediatric primary care for little kids 0 to 5, but schools are the essential service site for a reformed children's mental health system. We have to expand who does the work and who gets paid to do it. We have to create new benefits in managed care, specifically the family therapy benefit and the dyadic benefit, which I'll detail. And we have to focus on care coordination models and social model programs, meaning the future of mental health looks much more like a peer-to-peer interaction, a 12-step meeting, a mutual aid program than it does a psychotherapy session. So looking at the landscape, big changes are here and more are coming soon. So these are the key takeaways that I want you to hold. And I'm going to return to these at the end of my talk, just so you can say, geez, did I track it? But really big things are happening. We have the nation's largest Medicaid program. And by any standard measure, one of the worst for children. And I say this having billed Medicaid in almost all of its form, from hospitals to ambulances to foster care to juvenile justice to primary care to general acute care. Like, I learned these lessons making payroll and running systems. And for more than 20 years have been screaming, this is messed up, y'all. And I want to congratulate our Health and Human Service Agency and Department of Healthcare Services, because for the first time, there is an acknowledgement among our leaders that we must fundamentally change it. And that change is happening. It's important to know that Medi-Cal, California's version of Medicaid, is not one thing. Please, to call it one program, despite the fact that in some it's over $120 billion program compared to a $4 billion child welfare program. But you have to know the many faces of it to navigate it. In particular, to Richard's slides, you have to understand the ascension of the Medi-Cal managed care plan, meaning your historic partners as a first five or child welfare entity have been your county mental health department. That has fundamentally shifted. And now you must expand and create direct partnerships with your Medi-Cal managed care plan. There are new benefits in that managed care world, including enhanced case management and the dyadic benefit, that are really important to know the details of. So in addition to knowing the names and faces of Medi-Cal, you must know the specific names of the opportunities to be actionable. And I will invite you, implore you, to look at the new provider types as one of the greatest opportunities in the reform landscape. There are 4: community health workers, doulas, certified peer mental health counselors, and wellness coaches in schools. I'll return to them because, frankly, if we don't change who does the work and who gets paid to do it, entrenched interests will continue to profiteer on the suffering of low-income communities. And so this workforce stuff is really, really important. And maybe I'll just say it this way too. 80% of the over 5 million children on Medi-Cal are kids of color. 80% of licensed behavioral health staff are white. I got no problem with white people. White people are cool too, but that is clearly a problem we have to address. And then a last takeaway is I'm going to teach you how Medicaid works. Mine your local systems for the type of dollars that are eligible for a federal match. Those dollars are called certified public expenditures. I'm going to take you through that. So basically, get your hustle on. Don't spend a non-federal dollar naked. I'm going to say that one more time. Don't spend a non-federal dollar naked. My mentor taught me that I had to hustle as hard for federal matching funds as poor people do for rent, or I wasn't honoring their struggle. So you guys are all controlling non-federal dollars. Try to never spend them naked. So distilled, health plans are the center of the emerging Medi-Cal universe. Behavioral health access criteria are changing. Medi-Cal will pay for things it didn't pay for before, and it will pay for new types of providers. These are the essential things I want you to hold from the detail I'm about to share. So let's breathe out for a second because I want to take a step back. Why is behavioral health so important to focus on in the Medi-Cal landscape? Because it's what kills young people. Homicide, suicide, and injury. In fact, the reality of our current landscape is that suicide leapfrogged cancer and car accidents as a cause of death in the last 15 years. And it's us. Like, it's not kids. Mental health and substance abuse are the leading causes of disease burden in the United States. They cost more than heart failure and cancer. And as I mentioned, it's us, meaning uniquely American, this problem. Other Western developed nations do not have the same burden of social and emotional cost that we do, meaning we have created a toxic culture for children. We must now teach them how to survive and thrive in it. And by the way, I'm moving quickly here, but these slides will be available to you. I want nothing more than for you to cut and paste them. You don't have to cite them. The sites are all in the deck. We'll make sure you get copies of slides. You know, I encourage you to use it. Really what I'm saying to you or distilling to you is over the last 10 years, this is California data, inpatient admissions for self-injury for children doubled. Mental health days increased 50%, hospital days. Children in the California Healthy Kids Survey told us they were in crisis. We didn't listen. And this is actually a bad number. It gets worse. We not only rank 44th in screening, we rank 48th in access to needed mental health services. So I'm not attacking anybody individually here. So for folks who are work at DHCS or work in county health systems, this is no single person's fault. But to ignore or obscure the fact that we actually suck will not help us. And the existential question, it's not an existential, it's a fundamental question that I'm asking all of us today is, what will we do as system leaders when we wake up and realize twice as many of our children are trying to kill themselves? And COVID just poured gasoline on the fire. If you haven't seen this data, here it is. I again welcome you to use it. I'm not even going to read it because I'm tired of this data. But on the far side, if you look at this all together and you look at its impact on what we call level 1 pediatric trauma centers, this is Rady Children's Hospital, they have seen absolutely ridiculous increases in emergency department utilization for self-injury. And if you've never worked in an emergency department, which I have, a level 1 pediatric trauma center, they're small, 4 to 6 beds. So this type of volume swamps and overwhelms our high acuity services. So how did we get here? Well, 75% of mental illness manifests between 10 and 24, but that's when kids use the doctor the least. So if you remember from my previous slide where I said we have to reimagine where the work happens, it's not going to happen in a doctor's office. There just aren't enough therapists. Even if you wanted to give everyone a therapist, which we don't, but even if you wanted to, they don't exist. And diagnosis-driven models are only appropriate for some number of children. I have literally billed hundreds of millions of dollars of Medicaid-funded mental health services, and I will tell you probably 10 to 15% of the kids I served were actually mentally ill. The rest were dealing with really bad things that happen in their lives. So how did we get here? We don't have a common framework. Our public systems are fragmented. We have a lack of clarity over whether mental health is an essential benefit or a public utility. Anyway, more problems. So let's switch to a hopeful frame. What's happening now with the reform landscape is there is a general and universal acceptance that we need to do more and better, and things are popping. There's political will, there's community support. We have state leadership who has made this a high priority. Californians are saying repeatedly in the California Healthcare Foundation survey that this is among the most important issues to them. And we have an emerging consensus across both systems, child welfare and Medi-Cal, that the true drivers of poor health outcomes are tied to structural racism and poverty. And guess what? There's $10 billion. So it's way better to be doing this in the context of multiple $100 billion surpluses than it is in scarcity. But to take advantage of this moment, you and we need to develop new partnerships with managed care plans. That's where the checks are going to get cut from. So if you don't know the name of the managed care plans that serve the county you live in, it's time to learn them and start building relationships with them. We have to embrace the critical need to reform how we pay for and deliver stuff, finance. And we must mind the new provider types, building a system for people by people. And if I spontaneously combust and you take nothing else from what I say today, I hope you join me in reimagining mental health as a support for healthy development, not a response to pathology. So what is Medicaid? Medicaid covers 1/3 of all Californians. And we spend about $12 billion of our, it's now significantly larger than this. This is actually some older data, but it's of a $105 billion program, about 9% is behavioral health. Remember, despite the fact that behavioral health is a leading cost driver, we only spend 9% of our total budget on it. And Medi-Cal covers 1/3 of all Californians. But it covers half of all births. And when we go to kids, it's a far more significant payer. California took advantage of a federal opportunity to roll its S-chip program into Medi-Cal. So in 2015, Medi-Cal covers now all children 0 to 266% of federal poverty, regardless of immigration status, meaning it covers 5.7 million of California's kids, well over 50% of all children in the state. And despite those horrible numbers I showed you, very, very few children get access to anything at all, and those who do get the wrong kind of services too late. Currently, mental health plans are serving about 250,000 kids. Managed care organizations are serving about 210,000 children. Apples and oranges, not the same service. One is about 8,000 per child, one's about 1,200 per child. And when we look at how this shows up or compares nationally, we're in the bottom 1/3 nationally of spending per enrollee. And while children are 42% of all enrollees, they're only 14% of all expenditures. I hear you, Sydney. I'm using behavioral health as the term that the state uses to subsume both mental health and drug and alcohol services, the merger of those programs during Medi-Cal consolidation. And I agree, it's a stigmatizing term. Social and emotional wellness would be a better term. There was a 2019 audit that showed how significantly we are failing as a state in terms of 35 million children not accessing needed preventative services. So although eligibility for health services has increased, remember, almost 60% of all children are now covered by Medi-Cal and the EPSDT entitlement, a 30% increase over the last 7 years. And remember, it's important to understand that the line or eligibility line is different for adults than it is for children. Adults are eligible to 138, kids are eligible to 266. About 6% of all of the children access any care at all, and less than 3% are involved in ongoing care as measured by 5 or more encounters in a year. So 6% are known to the system, 3% are getting access to anything at all, despite all the numbers I told you. And if you don't disaggregate this data by race, you're missing the point of Dana's extraordinarily powerful lead-in. 81% of all children on Medicaid are color. The suicide rate is 2 times higher for Black boys than it is for white boys. The vast majority of children in detention are there because they have unmet behavioral health needs. Making healing-centered systems isn't just a matter of tweaking access or programs. It has to acknowledge the central role that poverty and racism play in impacting the social and emotional health of children. So I'm now going to teach you how Medi-Cal Medicaid is structured. So go with me, breathe out, open your minds and hearts. I have joked with Richard and Dana that if Medicaid makes you throw up in your mouth a little bit, I understand. I'm one of those people who actually thinks that Medicaid is sexy and that we can't solve our problems unless we get it right. So I'm committed to it. But let me teach you how it works. All of Medicaid, known as Medi-Cal in California, works this way. All of it, meaning every single Medi-Cal expenditure has 2 parts and 2 parts only. It has what is called a certified public expenditure, or that naked non-federal dollar, and the federal matching funds. One way to think of Medicaid is like it's a pot of gold sitting in DC. If you put up $1, you get $1. We have fancy names for these words. A CPE is that non-federal dollar, but it can be everything from like child welfare realignment to local sales tax to fines and forfeitures to speeding tickets. It can be tobacco dollars. It can be marijuana revenue. It can be Mental Health Services Act and Prop 63. Anything that's a public non-federal dollar that's not already being used to match a federal dollar is a certified public expenditure. An FFP is just the name for the federal match. So you might ask, with such a simple system, how do we screw it up so bad? And like most things, it's because when everyone is responsible, nobody is. Meaning that federal dollar flows through the state. And let's talk about how it shows up in the lives of children and families. First, and most significantly, it flows through managed care plans. And we just went through a reprocurement. So in January 2024, the kind of who serves what county changes a little bit. And in some counties, there's a shrinking of the total number of plans. And some counties are moving to single plan counties. So it's important to know this issue. But managed care plans are the single biggest sort of pass-through mechanism. Then your county mental health departments, your school districts can bill direct. FQHCs have a direct billing rate through their PPS and wraparound mechanism. Public health departments can bill for targeted case management and Medicaid administrative activities. Public hospitals have their own specific mechanism for billing. And the regional center is itself a 1915I and 1915H waiver program. So this is the architecture of our failure, you all. Like most people on this call probably couldn't draw this graphic. And we're asking low-income communities experiencing significant trauma to navigate this system. That simply doesn't work. And child-serving systems must also navigate this bubble, this bubble slide. And they are actually all structured the same way. And they have a common denominator, meaning all child-serving systems use the same structure, meaning there's a federal law tied to state enabling legislation, but they're almost all administered at the local level. That's true of child welfare. It's true of juvenile justice. It's true of early childhood. It's true of education. It's true of the Regional Center for Developmental Disability. The common thread the common denominator of all of them is Medi-Cal. Meaning Medi-Cal is best. I sometimes joke it's like 3M. We don't make the product, we make it better. Medi-Cal is best for kids when it's done in somebody else's system. The question we're asking and the challenge you have before you in your prevention plans is, do we have the will and skill to build new team-based models of care that integrate payers across fragmented safety net systems? That was the invitation Richard offered, and that's what 2083 is all about. And the reform landscape is a tool for you. It should be wind in your sails, meaning if you're tired of calling your county mental health department being told they have no money or they have no access, there are new opportunities for you. And I bundle them in 3 primary categories. The first is the Youth Behavioral Health Initiative, and I'm highlighting the workforce opportunities there, the dyadic benefit for our first 5 folks, and that universal fee schedule. That's the thing where schools become automatically in network for all managed care plans, commercial and Medi-Cal, beginning in 2025. There's CalAIM, which I'll break down for you, and then a series of budget decisions, including the schools money, the $4.7 billion now Community Schools Partnership Program, and the $3 billion Expanded Learning Opportunity Program. Schools represent a unique opportunity for us to do a lot of prevention work. So it's super complex. There's lots of bullet points here, but I would argue that you need to think through these in these kind of 3 primary buckets of reform funding opportunities. The Behavioral Health Initiative has 10 essential components, but there's only a couple that I would say you track carefully. Most of this is one-time money, so feed at this trough, right? Like, understand the evidence-based practice grants. Definitely partner for the upcoming school partnership grants. But number 10 is where the universal fee schedule is embedded, as is the workforce stuff. And particularly for those of you who work with little kids, 0 to 5, remember, who represent 18,000 of the 55,000 kids in out-of-home placement. The new dyadic benefit is one of the most important opportunities, and that's number 5 listed here, plan offered behavioral health services. That $800 million is the new dyadic benefit. And for those of you who don't know what the dyadic benefit is, basically it's healthy steps coded to managed care plans. So if you know of Healthy Steps or Project Dual Say or PCIT or trauma-informed cognitive behavioral therapy, basically low-income people interact with the healthcare system the most frequently in the first 3-5 years of their children's life, up to 12 times in the first 3 years. And up until now, caregivers couldn't get mental health services when they brought their baby to the doctor. But as we all know, babies don't go to the doctors by themselves. This benefit is basically an attempt to integrate behavioral health supports for caregivers during the first 3 years of their child's life. As I mentioned, schools are essential. The healthcare system needs schools because, as I mentioned earlier, children 8 to 18 have the lowest rate of primary care utilization of any demographic group. And so right when you need the doctor the most, in theory, right when you need access to services the most is when you use the system the least. So really the one way to think of schools is they're not a hand out to the healthcare system, they're a hand up, meaning the essential service location for children 8 to 21 really is going to be educational settings, schools and institutions of higher education. And also the finances align. I won't go into that here. That's a separate training, but schools have access to tons of money that's eligible for a federal match. So schools are really important is the key takeaway here. I mentioned that I think one of the most interesting opportunities is Medi-Cal's adoption of an expanded provider class opportunity, specifically these 4 new provider types that Medi-Cal has approved in the last 18 months. They are community health workers, doulas, certified peer counselors, and the wellness coaches in schools. So whenever you add a new provider class to Medi-Cal, there's a certain set of considerations you need to go through, meaning what is their scope? What are they allowed to do? What CPT codes can they bill? And which part of the system pays for them? 3 of these 4 new provider types are paid for by managed care. Doulas, CHWs, and wellness coaches get reimbursed through the managed care system. Certified peer counselors get reimbursed through the Department of Mental Health, your county mental health plans. So your scope says who who pays you and what codes are they reimbursed for. The credentialing question is how do you get to say you are who you say you are? Paneling means how do you sign up to get paid? Payer means which of the two payers pays you. And the rates are really the most important thing, is can you have a family sustaining employment with these new, with rates as they're written. For folks in the prevention plan, particularly the CHW benefit and the doula benefit, the doula benefit pays $1,200 a birth. The doulas say it works for them. We should be in a situation where no low-income woman should do their pregnancy journey alone. Again, like the doula rates are really good. We should be dramatically expanding access to doula services. So let's put this kind of in context, these new provider classes. You may be tracking that there's a number of new peer-to-peer programs in high schools funded by SB-HIP, funded by the Community Schools Partnership Program. We envision a time where a young person in a school could earn $50 a month being a peer-to-peer provider. And they could graduate and become a peer specialist. They could go on to be a community health worker. They could then become a doula. They could then become a wellness coach with an associate's degree or a bachelor's degree. Then they could already become a rehab specialist. Then they could enroll in a master's degree program and become an MFTI or an ASW, and finally licensed therapist. This is a reimagined health career pipeline for social and emotional support for children that gives us a pathway to creating a system for people by people, one that reflects the ethnic diversity of the Medi-Cal program. I mentioned that we have successfully removed diagnosis as a prerequisite for care across both the specialty system and the non-specialty system. It's a little fuzzy on the specialty system, I want to say. I feel like the state is backtracking a little bit on that, but in the non-specialty system, it's super clear. The new family therapy benefit is the first benefit in the history of Medicaid across the nation that qualifies beneficiaries for access to care based on an experience of discrimination, based on housing instability and food insecurity. This is a really, really important benefit. It brought the Z codes back to Medi-Cal. If you're a Medi-Cal geek, it's really, really important. And it was the foundation upon which we built the dyadic benefit. So this new benefit has happened, as well as I mentioned how fundamentally this new benefit reimagines the definition of medical necessity. And the babies don't go to the doctors by themselves is the name of the paper that's in your resource list that created the dyadic benefit. These two benefits, dyadic and family therapy, are part of what we call the non-specialty mental health system. Non-specialty mental health system is the plans. Specialty mental health system is the counties. You guys with me on that? Like the state keeps changing its names. Non-specialty is the managed care plans. Specialty is the county mental health plans. The non-specialty mental health benefit, where the family therapy benefit and the dyadic benefit are located, is new as of 2015. Basically, in order for the state to qualify for the money from under the Affordable Care Act, managed care plans have to offer 10 essential benefits, including behavioral health. So in order to comply with the federal regulation, the state created what was then called the mild to moderate benefit, what we now call the non-specialty mental health benefit. In addition to these direct clinical supports, non-specialty mental health, the state has proposed a significantly enhanced benefit called enhanced care management, ECM. This is a really important benefit for you and your prevention planning. It pays between $300 and $400 per member per month. I will say, as it was first rolled out, it was super technical and many providers found it difficult to navigate, but the state continues to make it easier and easier and easier. Children in child welfare are a defined population of focus. You can only get this benefit if you're enrolled in managed care. So if that pisses you off, it should, okay? Right now, about 60% of kids in foster care are fee-for-service. After January 2024, when the mandatory managed care plan changes hit, it'll still be about 45%. So this is a major point of advocacy for us, you guys. Like, for a new benefit to structurally deny 45% of kids access to that benefit, that's bogus. So we all got to work on this one. A fix has to happen. These are the 7 populations of focus under enhanced care management. The big one is number 3, meaning any child who qualifies for specialty mental health also qualifies for ECM. And the new specialty mental health criteria automatically includes kids in child welfare. child welfare system involved, so known to the system at risk counts. So ECM is a really big opportunity for your prevention networks. And community supports is basically a housing benefit. These are the 14 community supports. Most plans are offering 60 to 70% of them. They include everything from housing deposits. So really important for caregivers, again, to the first 5 community who's on this call today, understanding ECM and community supports and the dyadic benefit and how the 3 of them work together to give concrete supports and social and emotional support to caregivers. Really big opportunity for us to prevent little kids and being separated from their families. Sorry, got a little delay on my clicker here. The plans themselves are really important funders. And I feel like I'm maybe screaming at a little bit, you guys, but I really believe that it's important for safety net actors to get in relationship with their managed care plans. Like, the way I'd sometimes describe this is if you're Secretary Galley and Governor Newsom and you're looking out at the nation's largest Medicaid program and you're like, man, I got a problem, I got to fix it. And on mental health, I kind of got 2 horses to ride. I got the counties or the plans. What they basically did was constrain the role of the counties and expanded the role of the plans. The problem is the plans don't work with you. Plans don't know nothing about the safety net. So I would argue that had I been in their position, I probably would have made the same choice. The counties are deeply compromised on it for a number of reasons. And have really struggled to respond at scale on to the mental health crisis. The plans know nothing about your world, so they need to be taught. Plans themselves have access to dollars that you need to know about. The PATH funding is funding to access and implement ECM and community supports. So you should be talking to your managed care plans about PATH funding. They also have network building money. It's called the incentive payment program, meaning they can pay your community-based organizations or you to learn to become part of their network. These IPP funds are pretty significant, in the hundreds of millions of dollars statewide. There's the cited CBO capacity building grants. These are funding to providers to get under contract with the plans. These are a little bit tough to navigate because you have to have a plan agree that they'll contract with you. So you can't go at them without your partnership with the plan. And then there's a TA marketplace and regional collaboratives. Maybe someone knows more about this than me. I've been watching it. I still can't really tell. It just seems like every consultant and their grandma signed up to be a TA provider, whether they know anything about Medi-Cal or not. So I don't know if this is useful. So I'm very curious if people have been accessing it. From the grant programs to track, meaning these funds are directly managed by the plans, but statewide grant programs. There's practice transformation grants that are coming out, 700 million. They start in the fall. Evidence-based practice grants. The RFA came out this week for youth-driven programs, $50 million. Obviously, the community schools and the behavioral health workforce and infrastructure grants through HCI. Again, though, these are all hustle money. Do you know what I mean? Like you're just going grant to grant to grant. So looking to the left of this slide is building a sustainable ongoing revenue stream for prevention, whereas the right of this slide is big money, but kind of that thing of what I say is like quit one time in us state. Like we need access to like ongoing revenue to build these programs over time. So let me try to distill it for you. If you're looking for new money or money for your prevention plan, begin by specifically matching what you want to do with the reform landscape. So whatever your prevention plan says, or whatever you think is most important for the prevention in the communities you serve, try to crosswalk it to these opportunities I'm listing here. Are you trying to do more non-specialty mental health, family therapy benefit, dyadic benefit? Do you want your primary care practices to adopt the dyadic benefit? Are you trying to do more care coordination and concrete supports for housing? Are you looking at bringing in people who look like the folks we serve in your expanded provider class? And then are you talking to your providers about the conversion to CPT codes? This is a technical one, so maybe ignore this one unless you're a CBO who's working with the county mental health plan. On the FFPSA, you're doing your prevention plans and evidence-based practices. I think guidance is coming out shortly on payer of last resort. And then put that hustle cap on, meaning looking at opportunity to generate revenue either on existing expenditures or places where no local match is required. The new crisis service benefit doesn't require a local match. That should be expanded dramatically. And Medi-Cal administrative claiming is a way to claim federal matching funds on the work you're already doing care coordination. And that's a technical one, but if folks are interested, happy to talk more about it. And I can't repeat enough, getting to know the names of the people on in your managed care plan. And remember, 60% of enrollees are enrolled in a public plan, meaning you know the people on the board. And building those relationships is really important. So to kind of distill before I wrap up here, how are we going to reach families upstream with Medicaid? We're going to expand access points in schools and pediatric offices. We're going to screen for the social determinants of health. Things like Unite Us and refer out to concrete supports. We're going to create fiscal incentives for social care under Medicaid, including new benefits like ECM. We're going to do this service directory work and link people to concrete supports. We're going to expand the provider class, and we're going to eliminate diagnosis so we stop pathologizing the communities that we intend to serve. So what were my takeaways? Thanks. So 12, 17. I think I'll be right on time. Thanks. Takeaways. Big changes are here and more are coming soon. So like I talked about a bunch of stuff. My strong recommendation is pick one to understand, learn more about a specific thing. Don't try to eat the universe. The folks who are going to benefit most are the big systems because they helped write these benefits. But for you as child welfare actors, pick one of these opportunities to explore specifically. Got caught in the delay there, but know many faces of Medi-Cal, know the many faces, like who are you talking to? If you're interested in peer-to-peer programs, that's the mental health plans. If you're looking at CHWs, that's the managed care plans. Track the new benefit design, particularly the non-specialty mental health benefits, family therapy and dyadic, and the new managed care benefits, ECM and community supports. Mine the new provider type opportunities. Get your hustle on. Don't spend non-federal dollars naked. Health plans are the center of the new universe. Behavioral health is changing. Medi-Cal will pay for things it didn't before, and it will pay for people it didn't before. And I'm done. Thanks.
Thank you so much, Alex. Folks, there are some great questions in the chat, and we're doing well on time. So we will get to them at the end. Some of them may get answered by what Richard is about to say. Alex, thank you so much for presenting to us sort of one huge significant example of pots of funding that are available for child welfare and probation to support leverage so their funding, their prevention funding goes further. And many of you may be thinking, well, that's all well and good. How do I get at this stuff now? Now what do I do? It's there. I see it. Alex showed it to me. How do I get at it? Where do I get at it? Where do I start? So Richard?
Thanks, Kush, and thanks, Alex. Like a fire hose, right? Like 3 fire hoses all bundled together. So much opportunity. The state really deserves credit for expanding resources and access, and at the same time, if we do not coordinate the architecture for drawing down the revenues and then coordinate the care underneath that, it's all wasted effort or potentially wasted effort. So next slide, let's go into system of care a little bit in greater detail here and talk about some of the connective tissue that really has to be done. And I think maybe Alex and Kush are going to pass the control thing back and forth here for just a second. So we'll work on that. There we go. A quick primer in Assembly Bill 2083. It requires an MOU by and between at least 5 child-serving agencies. And as Alex has pointed out, it's time to consider the role of the managed care plans in that architecture, right? And whether or not they belong at your interagency leadership team table. While the system of care was written in 2018 to focus on foster youth who've been traumatized, I think there's general consensus and understanding that a legitimate system of care effort cannot apply to one cohort of kids. It has to apply to a much broader group of young people in your county or your community. As of earlier this year or late last year, under Assembly Bill 153, the state's going to invite a tribal role for your system of care work. So we have to be mindful of that. System of care is rooted in 35 years worth of national outcomes research, largely learning acquired through wraparound. And it really just confirms that interagency integration for youth in and around the care systems and the families that support them is the vehicle to get this done. Next slide, Kush. There are connections between, and we're going to try to draw both conceptually and concretely what some of these connections are between these reform efforts and the system of care work. The interagency leadership team that is required by the system of care work provides a foundation for the necessary planning, alignment, and management of the comprehensive prevention plan and the FFP associated dollars and the Medicaid expansion under CalAIM and the CYBHI and all the other efforts, right? Like, this is the point I want you to go away with today, is understanding that absent a structure to hold these reform efforts together, the maximal impact is going to be missing. The evidence for the need for a structure is present in the prior 40 years. We have in California endowed reform efforts in schools and mental health systems and welfare systems, and we have had often minimal impact. We've failed to draw down and maximize these efforts because we have not availed ourselves of the capacities that are present within partnership. Community impact includes a significant reduction in secondary trauma and avoidance of system entry. So when we talk about the big goals in California, system of care, activating reforms like FFPSA, CalAIM, and CYBHI really is the place where that impact will be felt. Navigating the Medicaid system, as Alex has pointed out, is super complex. In order to do that effectively, you've got to be in partnership with the people who know and understand that system, because there's no way that myself as a First Five commissioner or executive director or a child welfare deputy or a probation manager is going to understand the Medicaid system in any depth, right? I don't have time, I don't have capacity, it's not in my brain. But in partnership, I get access to the brains of the people that know and understand it and can help me maximize it. Next slide. We sometimes think of Assembly Bill 2083 as an initiative, and I want to challenge this notion. The Assembly Bill 2083 work is not an initiative. And one of the few things I'd hope you'll take away from today is to recognize that it is, unlike all other initiatives, a structure which intends to guide and support partners in their collective use of all of the other initiatives, many of which we've talked about today, right? That memorandum of understanding, together with the implementation of the state's practice model, which we may or may not get to here in just a second, provide that structure and the process for effective reform work. All the collective impact research, and most of you know this, suggests that absent a backbone organization, reforms like the ones we're talking about are really limited. That interagency leadership team forms the backbone. If you've invested in an ILT function or something similar, then you're at least at the table where you can converse, explore, inquire, and jointly design and develop programming that works on behalf of kids and families. Under the direction of that ILT, the next critical thing you can and need to do is figure out how to connect your fiscal managers, budget analysts, et cetera, in a consistent manner, not just to execute a CPP plan, not just to execute access to expanded or enhanced Medicaid dollars, consistently going forward, a re-engineering of how fiscal people in your community talk to each other so that they can effectively sustain the numerous opportunities that the state constantly throws at us in local jurisdictions. We are so well endowed in California. We are the envy of 49 other states in terms of the number of resources and the opportunities we have, but we often miss the chance to maximize them. The ultimate return of investment on the 2083 work is best measured in how it supports the social determinants of health, which we're talking about. So the goals and pursuits of system of care are aligned with the reform efforts that we've been articulating this morning. More services, and folks sometimes disagree with me about this, but more services alone, uncoordinated, won't make a difference for our kids and families. The more services will only be fully realized and impactful when they are coordinated, again, both at the organizational level and at the service delivery level. Next slide. So I think I've made most of these points, but what I want to spend a moment or two is the second bullet. The system of care mechanism under AB 2083 was designed very, very specifically to give local jurisdictions the capacity to align three critical elements of any impact, any change system in public services. It gives us a place to align our vision and our mindset among departments and agencies, right? So we have alignment about what the goals, roles, and procedures are. It gives us a structure, an interagency leadership team, and whatever cascades from that. And within that structure, it gives us a pathway then to put the functional elements together, to actually blend and braid money, to actually share private health information in a timely way, to actually coordinate care, to actually do teaming in all of its forms in a singular uniform fashion, right? To minimize assessment impacts. All of those functions of a good system are only present when the structure is also there. And here's the problem. We've done reform work for decades in California with great vision, but never in alignment with partners, or rarely in alignment with partners. We've had attempts at structures, but absent all three of these being done together, you just don't get the impact. The MOU provides that structured relationship between organizations so that we can hold the vision and blend the functions together. All right, so these three elements are all simultaneously critical and impactful. Next slide. Here's a quick look, visual, if you will, at the complexity of this. And it's what many of you hold in your local work. What I hope you can take away a little bit from today is the opportunity that's present within the Assembly Bill 2083 work. If you can find one or two other champions in other departments within your system of care work to recognize that it's not about foster kids, all right? That's where a lot of the impact will be. But the system of care work is about all of our kids. And if you can align that vision through your policy work, through your management processes, and then into practice, then we'll get impact. We'll get the kind of positive, sustained enhancements we're talking about. We'll get less disproportionality. We'll get greater access to care. We'll address the inequities in our systems. Next slide, Kush. Here's another quick visual reference and appreciation to my friends at the Department of Developmental Services a year or so back for helping with this graphic. But the outcomes that good reform work seeks they all require a container, and the AB 2083 interagency leadership process can be that container. So think of it as the vehicle into which we put all of our reform opportunities and all of our dollars, right? And when we do that effectively, we get effectiveness in a sustained way on behalf of kids and families going forward. The reason the system of care reform is needed is that, as you well know, because you deal with the impacts of this day in and day out, organization departments, agencies often don't share youth or student enrollment or entry data. So we struggle then to identify who are our shared youth. So we can't coordinate care because we can't even identify who they are. State and federal initial investments secondarily are maximized and sustained when the fiscal resources are matched, and it's other people's money that has to match those Medicaid dollars that Alex is talking about. If you're, if you know this term OPM, right? If you do any financial investing, we call OPM other people's money. Well, you're playing with other people's money here, and in order to play with other people's money to maximize your dollars, you have to be in partnership with them in a sustained, collective, collectively envisioned and held manner. And the system of care work gives you that vehicle like nothing else we've had in California. Yeah, thanks, Kush. Next slide. I want to spend a moment or two. That's good. Yeah. Go to that next one. Thanks. The system of care work has been informed over many decades now nationally, and there are known implementation factors to this 2083 work. These come from the University of South Florida. These 14 factors are the things that we, as designers of collective impact or change agents, if you will, at the management executive levels, these are the things we attend to, right? And I want you to just peruse these for a second and see the commonalities between these implementation factors and the implementation factors you've been responsible for under comprehensive prevention planning, right? Or Mental Health Services Act, or multi-tiered systems of support. They're the same, right? Like the science is the same. In other words, by attending effectively, sustainably, collectively to system of care, you're already then poised to do the implementation of anything else. So this is the grand skeleton or the framework through which you can effectively implement all the present and future reforms, because there will be more reforms. So think about these 14 elements and just recognize that if you'll invest in a system of care consistently over a period of 3 to 5 years, you'll create a system and a legacy for all future success going forward. Next slide. Just like the implementation factors are common between prevention work and 2083 work. Go ahead and give us the next slide, Kush. Just like the implementation factors are common, the goals are the same as well. So here's a very microcosmic sampling of the research on system of care work, right? So when we come into collective impact, over a period of a few years, we begin to see these 5, 6, 7 things and probably 40 others. This is an abbreviated list that comes from the good folks at the Georgetown Technical Assistance Center, SAMHSA funded place. But look at these goals and think about the goals of your CPP plan or the goals of your Medicaid reform, right? Or the goals of the CYBHI. The objectives of those reform efforts are endemic in and implicit in the system of care work. So once again, you enhance the reform work in California with these incredible resources by doing the system of care investment upstream. Next slide. All right, I think we've got a moment or two to ponder on my favorite topic, which is integrated core practice model. So hearkening back to the 3 elements of collective impact: vision, structure, and function. A vision and a way to harmonize across systems is found uniquely in California's integrated core practice model. There's a structure in place now with your 2083 work. And if we will all collectively implement the integrated core practice model, which I know we're not going to talk about in detail, but talk to your partners about what that is. If we do those 2 things in tandem, the research suggests we'll get to effectiveness, not just in these reform efforts, but of interventional work overall, like all interventions, therapies, attempts to improve the lives of kids and families. The impacts of that will be enhanced when we do collective, harmonious practices and alignment of vision through a structured relationship like an MOU. Next slide. I want to point out for a second that when vision is absent and we skip the blending and the sharing and the technical aspects of this implementation, we find ourselves like we have historically been on a grant treadmill. We're constantly chasing dollars, right? And I don't know if you've experienced it the same way I have, but in the last 5 or 6, maybe 7 years, the numerous opportunities of the state have been mind-boggling, and it's challenging even to keep up, right? With the next bling that comes out of Sacramento or Washington. we can get out of that process by being in partnership with each other, because we're leveraging each other's resources, our human capital, our people, our partnerships, our teammates, for the design and implementation work. So we can get out of that treadmill by being in partnership. We can share data on outcomes in ways that reduce the demand for data reporting and analysis, right? Because the kind of data that's required under comprehensive prevention plan work, for instance, is the same kind of data analysis that you're already doing for your system improvement planning or your performance improvement planning, or for your LCAP reporting, right? Your local accountability planning. Like, those data sets are almost always identical. And when we're in a high vision, high trust environment, we can maximize those opportunities. No true implementation happens really in a short term. So please recognize that this is a marathon, not a sprint. Those opportunities will emerge only as we stay consistent and focused over a long period of time. When vision is absent, we get higher job position and turnover, right? You've all worked for organizations where the vision was missing. And by having a collectively held vision for what these reform efforts are, we'll typically see less impact in terms of job turnover and the sustainability of our workforce. We will help then secondarily by doing all of these things by our community partners, by having a less vulnerable CBO network, right? Because we're sustaining dollars, we're maximizing impact of federal and state resources, and we pass that on to our contractors and vendors. So our community-based organizations are less than dependent on the whims of their local philanthropy, for instance, or their local fundraising to sustain their services. So the impact transcends the public agency, if you will. And finally, as we've pointed out, I think it's our belief, rooted in research, that when vision is present, we can finally address the inequity and disproportionality. When it's not present, we perpetuate those things. Next slide, Kush. All right. There have been a half dozen or so plans approved thus far under comprehensive prevention planning. I did just a quick analysis late last week of the first 4 or 5 of those. And I just want to point out that that I think there's some ambiguity in some of these early plans that's going to require some additional work. In some cases, the plans reflect some really good detailed analysis about the sources of prevention funding that are present. So the plans reflect that we've done the analysis in your planning process. However, there's very little concrete detailed language in the early plans anyway about which existing sources of prevention revenues are or will be leveraged. Like, the connective tissue is missing. The articulation of how we're going to actually do that is missing. And I'll point out and pause here that that's not the fault necessarily of our prevention planners locally. If you've written one of those plans, just know that that we're not yet clear about payer of last resort and other details that are necessary for you to actually do some of that. So please don't personalize this reflection. I'm just pointing out that in the first 4, 5, 6 plans that we've seen, it's not clear, it's not concretized how we're going to leverage those dollars. Most plans mention capacity building or planning for sustainability as ongoing processes. Some plans have a really nice articulation of the various streams available, but again, no details about how we're going to do that. So what this invites then is an opportunity in the next iteration, if you will, of CPP work as you get to implementation, thinking about how am I going to capture the long-term leveraging of these reform opportunities for Medicaid dollars, for the state investments, and the 4E monies that come with FFPSA, right? How are we going to do that in a concrete way so that it's in concrete? It's stuck there for the next generation of folks that come behind you. This will be really critical work. One more slide, Kush. Just to summarize then really quickly, more prevention alone will not have the substantive impact, and it will be time limited. If we don't do the connective interagency work, this will be a shot in the dark, a one-timer, like so many other reform efforts. Connecting partners, agencies, and systems into a true whole child and family-centered approach will lead to effectiveness of service planning and sustainable funding and programming. We can get out of the scarcity cycle. Scarcity will always be present, but we can deeply mitigate scarcity by being in partnership with each other and actually sharing monies across interdepartmental relationships. Parallel opportunities are only known and discoverable when you're all at the table. And this includes our managed care organizations, right? So invite your managed care partners, because as Alex has very clearly pointed out, an increasing ratio of resources is going there. Because much of the secondary trauma to families occurs as a result of system involvement, let's recognize that addressing disproportionality, equity, and access issues really demands that we do the pre-work of integrating our delivery systems. There's a tendency to skip over the hard work of being in a collective and get to the implementation of a reform or a new opportunity or a new grant. I hope you'll take away, among many things today, the recognition that until and unless we invest in one child, one system, all those opportunities will just be a cycle that we'll be chasing our tails, as we have for decades in California. Kush?
Thank you so much, Richard. And you know, what I'm really taking away from what you're saying, connected to sort of what I see in conversations I have with jurisdictions struggling to meet the vision of all this prevention planning we're doing, is time is ticking. That's true, right? And so there's this urge to quickly go and get into contracts and spend the money without taking a moment to pause and look. So I just love your urging to, okay, so the plans did what they needed to do for this part of the journey to get the funding going, but at implementation, it may be worth it for a moment to pause, turn on that light switch and look around for a while. Thank you so much, Richard and Alex. We've got some great questions brewing, and we're on time. So I think we can get to most of them. So here we go, folks. We are at questions and discussion. And I'll tee up these questions that are in the chat, but if they require some more depth and some more nuancing from the people that asked them, if you're still here, I might ask you to come off mute and interact with our presenters. So, first question, and this is from Sid Gardner, and Alex, I'm going to throw this to you. How does the dyadic benefit respond to the great gap in family-centered substance use disorder treatment that keeps parent and infant together?
It probably makes sense for us to have that conversation offline, but very directly, it doesn't tie access to social emotional support to mental health diagnosis. And it's provided in the context of the well-child visit. Like, really important for those of you who track like integrated behavioral health models. Like, historically, we've had a therapist co-located in a clinic. This is very, very different. Healthy Steps basically puts the mental health clinician in the room during the well-child visit and talks to the parents in that way. So a lot of the Z codes and the CPT codes associated with the dyadic benefit have nothing to do with diagnosis. And there are more questions about social determinants of health, the challenge of being a low-income mother, where you get diapers, how do you handle when your kid cries at night? Those are the codes you bill.
Great, thank you.
Feels a little bit inadequate, Sid, but I'd love to talk to you more
Alex.
separately about the package of codes that you can bill.
Great. This next question, I suspect both of you will have something to say about it. How at risk do you think all of this progress is, with the state potentially facing years of major budget deficits, similarly with the reckoning of the federal debt ceiling? How do you think all that is going to impact what you've been talking about?
Mm-hmm.
If you had a crystal ball.
So the volatility of the safety net system is as much tied to how realignment is structured as the things you named. So remember, child welfare and behavioral health realignment are both a function of sales tax and vehicle license fees. So think new cars in the mall, And then the MHSA is a function of millionaires. So think new cars, the malls, and millionaires if you're interested in mental health. Those are hugely cyclical. So when you need them the most is when they're at the lowest. The managed care plans have far less volatility because you remember how I said counties get these dollars and then they pull down a federal match. What makes managed care plans different is with the dollars they spend are already matched. They get paid in capitation. So their resources are significantly less tied to the economic factors that create the boom or bust cycle of California's safety net system. Are you with me? So if you're a child welfare agency or a local mental health department or a CBO who's been contracted to these county entities, actors, you know that as soon as millionaires do worse or vehicle license fees drop or sales tax drop, you are living in scarcity. The managed care plans don't face the same challenge. Now, it doesn't mean to obscure or deny the fact that we are in a significant, budget crunch compared to the last couple of years of $100 billion surpluses. But Community Schools Partnership and CYBHI, the appropriation has already been made. So those dollars are already in statute. They're not going anywhere. The DADIC benefit is per AB 133 is live and adopted. As you all know, you can't cap a service to a child under EPSDT and Medicaid. So I would say the managed care benefits are largely safe, and the grant programs of the CYBHI and the CSPP are also largely safe.
I just offer an additional thought around that scarcity, cycles of scarcity have always been present and always will be. My experience is that the way through those down cycles is to be in partnership. And I'll tell you very quickly, the Reader's Digest version of this is I was running a department in 2008 through 2010. Some of you were around then running budgets, right? And my fiscal managers came to me at the start of that cycle and said, your workforce is going to go from 210 to 163. And your budget's going to be reduced by 32%. Not a small amount. And what I did is I went to my interagency leadership team partners and I said, this is my budget situation. Tell me about yours. And I will say that over the next 3 budget cycles, I laid off nobody. We had no reduction in force in my department. I went to my partners and I said, what can my people do for you? And we retained every single person. We re-engineered a hell of a lot of jobs, right? Like we did a whole lot of work. Talk about putting your hustle cap on. Like we found and created different things for people to do, but we laid no one off and we retained the vast majority of our services only because I had partnerships that trusted me and that I could trust, right, to get us through the scarcity.
Richard, thank you. Let's stay with you. Another question from Sid. What's the most recent useful evaluation of 2083 efforts and outcomes in California?
Sid, this is one of Sid's favorite questions, and I love it when he asks. And I'll reflect a very short answer that California has not yet evaluated its 23 effort, right? Like we're 3 years into implementation, and I use that word very softly. So we don't yet know. We'll get there.
And there's just a follow-up concern that ILTs may not be addressing the concerns of all children, and just an acknowledgement that there's a lot of variability across counties as to how the ILTs are rolling out.
Correct. Yeah. When I say that implementation has been loose, that's like an understatement, right? Like we know that there are some counties where interagency leadership teams feel like they can meet 4 times a year for an hour and somehow change the way they do their work. It's pretty silly. It's not going to happen. So we have to do a much better job overall. Some counties are doing it really, really well, right? Some big counties are doing it really, really well. But we got to get 58 counties to recognize the power and value of partnership and to invest in something much more intensive in terms of building an architecture for not just foster youth, but for all kids.
Excellent. Thank you so much.
Chris, I have a quick comment there, if you don't mind.
Absolutely.
I'm reminded about like collaboration, collaboration to collaborate is tough. Collaboration on the execution of a task, you know what I'm saying? So I mean, this is like a personal reflection as much as a professional one. Like, get in a room and talk about racism, nah. Build a house together, or play on a sports team, or make music together, yeah, right? So what I would almost suggest in some ways around 2083 is like, there are opportunities that the legacy county systems must pursue together. Identify them and seek them. Like, new money is a great thing to collaborate around, right? Giving me your money is sometimes tough to collaborate around. Better leveraging our money is a good thing to collaborate around.
That's right.
You paying for the stuff that I'm trying to do, not such a great thing to collaborate around. Are you with me?
Yeah.
So like 2083 is definitely, I'm a big supporter of it. And Richard, I love your work as the table and container, but identifying a specific thing to do together feels to be an essential way to move that work forward.
Exactly. I think that's what I'm trying to say, Alex, is a local county has to have an implementation plan. You have to identify priorities within the development of that plan. You can't just sign an MOU and then meet for an hour a month and clap your hands and say, look at us, right? It's way more complicated than that.
There's another question about the system of care, and you mentioned changes are coming in January 2024, Alex. How will the managed care part of the house, or how should the managed care part of the house interact with the system of care part of the house?
The only way to answer that is I do not know. And anybody who says they do know is selling you something. So I would recommend, again, find a specific action to collaborate in the opportunity landscape of the plans. What I know is that if you're looking for a new check for more money to do something more that you believe works, with all of Richard's very important points about just more isn't the only answer. But if you're looking for resources to do prevention, they are more likely to come from the managed care plan in the short term than they are from the existing county finding landscape.
Yeah, so I will sell you something, and that is take your managed care plan, lay us on people to lunch consistently, and ask them about their interest in coming to your in your agency leadership processes. Like, invite them into your ILT and talk to your ILT partners about making them a partner and have them sign off on the MOU. You got to have an MOU with them anyway. Why not build that into your existing 2083 MOU, right? So make them a partner. And then, as Alex points out, you can't lead with your hand open. You got to lead with your own carrots. So you take your bunch of carrots and say, this is how we can help you. Do you want to play?
Thank you. More a technical question. Alex, will the dyadic benefit only be in the medical provider's office?
Yeah, no, I mean, it was designed that way. So just to be super clear, if you're familiar with Healthy Steps, and again, to the first 5 people on this call, there has never been a more important opportunity to expand caregiver mental health than the dyadic benefit. It's literally getting adopted in 6 states. It's a really, really big deal. We've never created a new benefit in Medicaid where the patient is already in the room. Mom is there. It should be the single largest expansion of mental health services to the Medi-Cal population in the history of Medi-Cal in California, because mom is already there 12 times in the first 3 years of their child's life. And they don't have to meet medical necessity criteria to access it. They just by showing up and bringing their baby in and being low income, they qualify for the benefit. So it's a really, really big one. And it's hard. The plans don't know how to administer it. Providers are stuck. There's a bunch of technical fixes for the FQHCs. So folks who want to know more about the dyadic benefit, either reach out to me, or the UCSF Center for the Advancement of Dyadic Care is a really great resource. But just think of it like Healthy Steps crosswalk to CPT codes is the best way to think about it if you're a first 5 person. the answer to your question of, it was designed to be available in primary care, and certain codes can only be billed during the well child visit. But there are applications of the dyadic benefit that should be available outside of primary care, and it can't be restricted, right? Remember, once you create a benefit. So I'm kind of hopeful that people like you will come up with amazing, creative, awesome ways to claim those codes. More likely in the short term will be to bill the family therapy codes. Again, they do not require a diagnosis, 980, though that whole code class. So I think that was the answer specifically. I think that was it.
Thank you. And so, yeah, there was a question in the chat, and Dana, thank you for answering it. Are there opportunities through this type of venue to bring managed care leadership into the discussion, and can this venue model the integration? I'm presuming with this venue you mean our learning forum or forums like this, and we've thought about that, and I just want to give folks a sneak preview of what we're going to do in part 2. Is we are going to have a panel of folks that touch all parts of this endeavor. Folks who hold the county purse strings, folks from managed care, community-based providers, because in theory and in principle, we get it, right? But there are nuances when these things get implemented, and it looks differently based on where you're sitting. And so part 2, we invite you all to sign up for part 2, where we will have some of these players on a panel in the discussion. And Judy, if that was not what you meant by this venue, go ahead and put that in the chat. All right, we have one more question. Or maybe we have 2. Alex, when you were discussing plans, is this in reference to the MCO's MOUs that are being created?
Question. Yeah, so there's a bunch of stuff happening trying to link the plans to the safety net systems. And the most recent effort is the MOUs between the plans and child welfare systems that the state is taking public comment on right now. And Dana, we should probably include in our resource list a link to those current conversations. The managed care plans will be hiring foster care liaisons. That's something that's coming. There's going to be new activity stipends in the next 1115 waiver. Long-winded way of saying is there is a lot of energy at the Department of Healthcare Services, in part because Michelle Bass, the leader of the Department of Healthcare Services, is a foster care ally and advocate and a really good person. There's a lot happening now to promote and move forward the partnership between Medi-Cal and foster care. But again, the energy appears to be coming largely and primarily through the managed care plans. So the plans, I wasn't referring to that specifically, but that's a great point to raise. And those MOUs are currently in construction right now. Let me say one other thing. There has been historically a requirement for the specialty mental health plan, the county mental health plan, to have an MOU with the managed care plan. And it's basically a processy plan. Like, I'll share my data with you, you share my data with this way. And it turns out to be relatively unimpactful. What we want from these MOUs is a specific commitment to services to identified population. So the feedback we've offered at the trust to these is these MOUs don't go far enough to say what more and what better is going to happen specifically to child welfare system involved kids.
Thank you. And I just want to lift up, I don't know that it can be a question, because like somebody noted, nobody's been able to crack this nut well unless you know of examples. But data sharing across systems is sort of a critical foundational piece to this happening, in addition to conversations across tables. And there's just concerns about that in the chat. I don't know if there's anything else to say other than to acknowledge that, but if you have examples of where data sharing is starting to work across these systems, that'd be great to hear. Right. I think that ends all the questions in our both the Q&A box and the chat. I will go ahead and bring us home and turn it over to Caltrin.
We just want to thank everybody for participating. Thank you to the panelists, thank you to the participants, and thank you for your questions. We will have a survey to be dropped right into the chat, and you'll see it there now. By clicking that survey, you'll have access to a few things. It'll be a very short survey with some questions, and at the end of it will be a certificate of attendance. Also, be on the lookout to your registration email for a follow-up that includes a recap and a replay link. Thank you all so much, and we'll see you next time.